So I have to tell you, this is really, really exciting, right? It is really exciting. This is a little audience engagement here because I don't like to be up here alone. I like to feel like everyone's up here with me. So how many vendors do we have that have headsets that are out there in the area over here? Raise your hand. A few over there, maybe more trickling in. They're probably out there right now, right, Walter? All right. How many folks here are veterans that use the system? Or a veteran? All right, good showing there. What about clinicians that are using headsets in their clinical practice? Ooh, there was a lot of those. Awesome. What about other central office staff that are clinicians or doing this work? All right, great. And what about other administrative staff that are out there supporting this effort, either at the central office level or in the field? Awesome. Who did I miss? What's the other? Advisors. Advisors to our team. Susan, Skip, Walter. Excellent. Who did I miss? Go ahead. Yes, that's right. University of Georgia is looking at using VR as modality for teaching and training. And I think we also have someone from the Office of Academic Affiliation in that way. And so I bring this forward because this is a community. And when you think about difficult problems that we have locally or even nationally, it takes different viewpoints to get the work done. And that is what I am incredibly inspired by, the diversity of the people that have shown up, that have come together, that are making connections here yesterday and today. So I want to share with you, as someone who, after Ann read all the things that I've done, it just means I've been around a long time and I like driving a lot of change. And I've had the opportunity truly to do that with Ann and Caitlin and the team and some amazing advisors. So I'm going to share with you where I think that we're at a little bit, where we've been in the last year, and then where we're headed. So I'll try to not make it too long and we can keep moving along. And I hope that there are slides that might be, okay. They're on the side. Go back. Oh, okay. Thank you. That's helpful. Oh, and it has the time. Perfect. All right, so I want to talk a little bit about last year. And where we were at. It was about 10 months ago, and we came together and we thought about where were some of the focal points and what we wanted to strive for this next year, right? Who was here last year? Ooh, we got a lot of repeat folks, but then some new ones as well. Excellent. And we came out of the Immersive Summit last year making a few promises, looking at increasing more headsets, standardizing training, and ensuring that we had better access to our data. And I can't remember if this is next slide. Yeah, it goes into it a little more detail. It does. So I stood up in front of everyone and I said, we're going to get to 10,000 headsets. And the crowd went wild. And while we haven't gotten to 10,000, we've almost doubled the amount of headsets, right? And tripled the amount of headsets that we have in distribution. We're at 3,500. For those of you who don't know, we've had some financial slowdown and really had to tighten our belt, and that is partly responsible, but we're not going to stop. Right, Ann? Right, Caitlin? We're not stopping. We've increased the number of folks that are participating in our community of practice up to about 3,000, and then and we're going to keep going. And maybe what we focus on is the number of staff that are using headsets as part of their practice, not just the number of headsets into the future. So that's where we've been. We also committed out loud that we are going to increase the amount of training experiences. Well, we have NOLA University keyed up and pretty much ready to go, but we're not allowed to have a lot of big travel right now. So we are looking into virtual, and I want to highlight some of the work that Caitlin has done with the standard operating procedures to help support our work in delivering home use of the devices. So in some ways, that is a bit of training. And as was mentioned, the clinical resource hubs in the last year, They came to the summit and they are really excited about using this modality for care delivery in pain and in mental health and in about 9 VISNs. So we're really moving forward as an accomplishment over the last year. And better data is still evolving. I know that Anu and others are working toward standardization of the data, and you're going to hear more about that in the Made for VA presentation. So that's where we've been since last year. And where are we going? Where are we headed? I'm going to share that with you as soon as I highlight the many nights and weekends, right, Dr. Bailey, of working on this manuscript. I know that some of you have seen it, some of you may not, and I want to, it's the citation is at the bottom, Bailey, Kirsch, Rollins, Lessons Learned in Early Scaling of Immersive Technology, in the New England Journal of Medicine Catalyst. This really represents a milestone in our very early work, and all of the work that you have contributed in this room, many of you at the sites, to help us understand what works, what the barriers are, what the facilitators are, where we're headed. But I am really excited to say that we have moved past this. We are past the early part of the diffusion of innovation curve, and my good friend and colleague, Dr. Persky, is nodding because she knows it's true. We have moved past those early adopters. We are moving, and it's because of this community, to all of the folks that are making the way forward, and this is the way we do our business. All right, shout out, right, Jared? This is the way we do our business. This is the way we deliver healthcare in the VA. We are a global leader, and we're moving into what's next and what's better. So I want to move to some of what the paper says, because some of it is still true for those of you that are working with some of the naysayers in your medical centers. I don't know, what is this technology? What can it do? You still got to get heads and headsets. It's still a part of our way forward. We need to continue to drive equitable and personalized access. The clinical resource hubs we have a presence and participate in about every quarter when they have their face-to-face meeting. And we're really still, and you'll hear more, looking at data. Data in 2024 will enable us to be able to learn from what patients are experiencing, the engagement level, and what I started thinking about was if we collect data and information from patients, with consent of course, it will help us understand how they're using devices. And if they're using VR for pain care, and we collect data, it should come back to the provider that says, patients like this who have had 6 sessions in VR for pain could now have also succeeded in this other session. So it helps us learn how to best guide our care and continue to support and drive patients. So good, I've got some nods in the audience, so I know I'm going in the right direction. And we always want to think about partnering with the technology and vendor community to ensure that this really represents what the providers and the patients need in the experience themselves. I think that this is becoming the way we live our life now, and not, oh yeah, I forgot about that. We better talk to that company about that. So I want to ensure and thank you for continuing to drive that piece forward. It's been a part from the beginning of how we do our work. All right. I had a conversation with the Made for VA team the other day. It was the way, essentially, again, this is my doctor brain, how do we make standardization out of the work we're doing? Because that truly, for me, will drive this into the system, where it's easy to use, where people who say, I don't know if I'm going to use this, but it's kind of easy to use, and my patient's asking me about it, I'm going to do it. That is the next step for this team, and that is something that I feel like I can contribute and have experienced. So I said, I need to see it in terms of a patient and a provider, right? I walked into that room on Monday, and Laura and Amber are going to talk shortly. But I needed to have a visual to show you all of how this needs to go. You have the provider, you have the patient on the left-hand side there, and to me, it has to be treated like a medication. It is in some ways a prescription. and you go into CPRS, which is our current electronic health record in most medical centers, a little cerner, and you order it, and you order why and what the indication is, and you know the content that you're going to get, and you're able to then get the headset either in the clinic delivered to the patient or the headset sent out to the patient with specific content on that. Now, there's a lot behind the scenes that you're going to hear about that is going to help really make that happen, but this is where we need to go. And that headset then, with consent, will enable the kind of data that I talked about. The user and how long the user, that veteran, is in the headset. How long can we collect eye data to look at the intensity of the experience and glean outcomes related to that? So we know that data in 2024 is power. One of my friends here, Walter, has always shared that with me, and thinking about AI, and we need the systems that will enable that. The piece that is really important here is, I didn't want to forget to mention that patient-generated health data could come out of the headsets using haptics, and that then, for my friend Dr. Josephs, wanted to share that would be part of where we're heading also. In terms of what we're missing right now is the workload credit for the work that is being done. How do we drive this? I hope that some of the medical center folks will appreciate this, but we can't wait for the FDA and for codes that are billing. We need to move forward and drive forward now. And a note that will enable the additional time to be coded and billed for in our system, creating more reimbursement coming back to the individual providers and the medical centers will facilitate more headsets. So I hope that that makes sense to you. And I was sitting there thinking about this, talking about this, asking Dr. Singhal if this made sense when Ann texted me a picture and said, "You better get in here," because Liz and Sheena from, where's Gulf Coast, is that right? Gulf Coast. It's Biloxi, but Liz and Sheena are doing this in Biloxi, Mississippi, and I walked in, and there they have been trying really to do this essentially since January, January, March timeframe. And if anyone else is doing this, we want to get a work group together, and we want to ensure that we can create some of that pathway of how we do this. In addition to some of the work that's been done with Caitlin and the prosthetics group, we need to continue to drive this loop forward. All right, I better keep going because my timing says I have a minute left. But I am at looking ahead. And the looking ahead is the standardization that Made for VA brings forward, which includes the clinical workflows that I shared in the previous slide, the IT integration points around data and cloud management, and this thing called mobile device management. You know, I learned a lot when I was a resident and took care of patients for 17 years in clinic with veterans, but mobile device management wasn't one of those things that was on my boards. But what I understand is that the management of the devices can ensure that appropriate content is on, that it's added or deleted to meet the personalized needs of veterans, and that we can then account for the use, and that is something that in the digital health office, there's a group that's doing that work, and we're going to end up connecting with that person. I also really thought about what do we need to do yesterday after a few folks talked to me about this. What about the contracting? What's the segue for the vendors that we are using, that we're seeing good results with, to continue to be a part of our system? And we are committing to look at better ways, not just with CRADAs, but for contracting. If you're contracted to be at 3 sites, how do you then become a part of our system in contracting for more? That is of a really high level of importance. I want to mention that there's been a lot of interest from the Office of Academic Affiliation in how we use immersive in our looking ahead way forward for training doctors and nurses and social workers and pharmacists into the future, and as a modality using the simulation lab, and Eric Bruns is here, the director of the lab, so thanks for coming here today as well. And I think that is my last slide. This was my, I think, second experience, right, Dr. Bailey? And I will say it was 2 years ago at the summit that we met, and I was first exposed to this type of therapy and this modality for care delivery, and it truly changed my life. Not because I had a medical ailment that I needed it to change, but I could see where this fills in the gaps for patients who have chronic pain, who can't get out of that chronic pain, and they don't want more medication, and they've meditated, and this gets in there, and it touches those lives. Dr. Ann and Caitlin share stories with me on a daily basis, Evan as well, patients that have needs for feeling isolated and lonely, and we can meet them where they're at in their own homes. So I'm going to end by saying that I am so incredibly proud of the team, excited that you all showed up today. Thank you for what you're doing. We are a community. We're not even at the beginning anymore. We are transforming the way that healthcare will be delivered into the future. And we are in VA, with all of your help, a global leader, and will continue to be so. So thank you and have a great day.